little elastic spring back to happen. So these three fundamental principles have to be met. There has to be a proximal fixation, there has to be a distal fixation, and the maximal width should be at the fracture site, pressing against the inner cortex. And when you bend, there was people used to bend in all sorts of ways, but generally you measure the most narrowest part of the medullary canal, roughly about 3 times of that you can bend it. But sometimes I do insert with minimal bend, especially only at the nail tip, and it just finds its own way. So it's not a hard and fast rule, but it usually comes out nice. And when you choose a size of the nail, you have to make sure that you have to have an equal size of it. If you use unequal size of the nail, it has got some mechanical disadvantages, and also this is generally the measure that you use. You measure the medullary canal width, and you assume that you're going to leave 1/3 of the space free, and the nail is going to occupy the rest 2/3. So you just choose the nail according to that size. So these are the sizes these nails are available now. Earlier it used to start from 2, and now even the 1.5 is available, which will mainly for children's forearm fractures. So and all the way to 4. And there are end caps available, especially useful for distal femur fractures, where you are opting for TENS, and you can get this additional cortical purchase and security there. So this is in brief, how do you plan for TENS? You leave roughly about 1 inch away from the physis when you're doing a femur. As you insert, you are inserting with the point pointing distally, and then you turn it around as soon as you enter the mid metaphyseal area, and then introduce it up to the fracture site. And if you have the opposite side, you introduce it till then, and then advance 1 nail, and use this nail to reduce the fracture and subsequently introduce the other nail. So this point A, where there is the end point, and as you can see, it is pressing against the cortex, and that is very important to achieve our aim of 3-point fixation. We need to have a point of fixation here. But there are situations, especially in distal femur fractures, where you can't do a retrograde nail. We have to do antegrade. And then when you do antegrade, you don't have the medial option, entry option. So in that case, you need to contour the nail either in a C curve or a very slight S curve. So one nail goes from lateral, and then it enters the from lateral to lateral, and the other one goes lateral, and because of the S curve, it takes a bend and goes medial. So this is how you enter. You enter in the subtrochanteric area and in an anterolateral cortical position. And then this is the final configuration these nails end up in. So that's enough theory, and we'll see how we can, in case scenarios, how this works out. So this is child, just about a 4-month-old child, and you can see a fracture. The child fell from mother's lap. This was initially treated by my colleague, and this is just to point out the pitfall of treatment. I mean, most of us would opt for a hip spica here, and so the choice of fracture treatment is pretty obvious, but you can see the way the spica is ending. It is not even the spica. This is some kind of strange long leg plaster which was applied, and the top end is here, which means that it's just at the fracture level. So obviously a fracture which was to start with undisplaced has now become displaced and angulated. But this also shows you what kind of tolerance limit you are dealing with in children's fractures, especially a child as young as 4 months. So in spite of all this and the angulation, you can see that the remodeling is starting now, and it is quite well remodeled at the end. So we do have that remodeling potential to play with. So quite often, even if it is there or thereabouts, it unites. And as I think Professor K. Wilkins used to say, that as long as you put, in a child's bone, both bones, the same limb, it unites. So it's that kind of remodeling potential a child as young as this has. This is a slightly different scenario. I thought of choosing different kinds of scenarios rather than speaking only about the routine traumatic things. So this is cerebral palsy child who is completely bedridden, GMFCS 5, fully activity daily dependent, and this fracture was sustained when the mother tries to abduct the thighs for a toileting purpose. So obviously the bone is very weak, and you can see some rickety changes in the upper epiphysis here, and it is widened. So how this is the position the child is lying in at home, and this is the only position the child can lie in. Any other position is not possible. The child just turns on one side. You can see a large pressure sore of some time ago, which had developed, and then subsequently this posture was adopted. So you can approach it in a traditional way, but I chose to do it in a way that will allow you can just fix the fracture and deal with it. But here what I have done is I have used the fracture as an opportunity to do a valgus so that there is a slight abduction of the thigh possible, and future such fractures get prevented. So the toileting also in this case becomes easy because you are abducting the distal fragment away. So you can be slightly creative with these solutions and do the best for the patient. So the fracture can be an opportunity in some situations like this. So this is an older child. This is about a 12-year-old child, but a very obese child. And this child sustained the fracture, slightly distal fracture, and it was associated with a Lisfranc injury to the same side. So again, 12-year-old, your option is a transverse fracture. It is a length stable fracture, and it is slightly distal but not too distal. So the option here again is pretty straightforward. You can go with tense nailing, and you can see this. I have ensured that there is proximal wedges, and these two are actually engaged in the bone, and in fact, this nail is slightly. It's just like this. It is flush with the outer cortex, and you can see the point of maximal contact is at the fracture site, and there is a distal contact as well. So we have obeyed our principles. There is a 3-point fixation, and it is a transverse fracture, quite well reduced. We could manage to reduce it close to. So there is a little bit of a comminution here, but in spite of that, you can see adequate cortical support is there. Because it is an obese child, a very obese child, TENS choices imply that you are obeying the principles of TENS. If you don't, then with TENS, you could land up in a lot of difficulty, as we will see in another case. So what about this? This is a very proximal fracture. It's kind of a long oblique or a spiral. So this is a 10-year-old boy. And there may be people who may opt out and say that it is length, probably not length stable, and then go for submuscular plating. We still managed to do the TENS, and we introduced a screw here, a percutaneous screw, and you can just see that we've done some temporary reduction measures with shunt spin here, but we managed to get a reasonable reduction and a good union. And this is not an ideal solution. Maybe we may be better off with submuscular plating, but this is still possible. So again, a very similar fracture. So we are just trying to see how different this can be managed. Again, a very similar fracture pattern, probably a little bit more proximal extension to this. And this is sustained by a road traffic accident. It is a low energy road traffic accident, actually. Just fell from a two-wheeler. So again, we use TENS, and you can see the quality of reduction here. So I put this case to illustrate the point that there has to be a proximal purchase. And you can see that we have introduced the TENS nail far up into the neck, and actually in the lateral view, it is actually abutting the cortex. And again, a long purchase, and you can see the cortical, you can hardly make out the fracture line itself. So we managed to get a very good reduction with this, and we opted for TENS. Otherwise, submuscular plating is an option in this as well. But If you have adequate support, cortical support, and there is no comminution, even in a proximal fracture, you can introduce TENS, just pure TENS, closed reduction, and get away with it.
So this was an 11 years old, right?
Yeah.
It's
11
the
years.
case
Sorry.
match.
Yeah,
Okay.
it's a typo, sorry.
Yeah.
That's a typo, sorry.
Right.
So you can get away with that. So again, another similar fracture. Again, a proximal fracture with extension almost to the subtrochanteric level. And again, it's a low energy fall. So these fracture patterns are sustained in a low energy in a rotary force. So this is a 12-year-old. So this was done by my colleague, and here you can see that it was TENS with an additional circlage. Circlage traditionally is not used in fracture patterns, especially said to inhibit. If you read the older books of internal fixation, circlage is generally frowned on, and then it inhibits the bridging callus. In this situation, this is a good choice because you end up with an adequate cortical support. So this is something that you could consider. Now, another child, 7-year-old with a road traffic accident, a similar fracture, but in this case, you can see that there's a large butterfly fragment. And we have a few options here. Obviously, TENS may not be the option because there is a cortical support which is missing, and TENS may be a bit unstable if you introduce that. Submuscular plating is an option in this age, but we reduced it on table and we felt that the reduction could be achieved with hip spica. So this is a tool that you have to consider in your armor, that this is an option that you can consider even in a child as old as 7. So that you can see how well it reduced back and it has healed back quite well. So don't just forget the art of spica. The art of hip spica is very important. You can reduce close and maintain these fractures if you counsel the mother properly. So again, the family care system is very important. Generally, internal fixation devices require less intensive care, and that is a potential option if you feel that the family is not up to the mark. And there may be social structures which don't allow caring for, say, about 6 weeks in a hip spica. Especially in a female child, the toileting and all that is an issue. So there are considerations, but this is definitely something that you should keep in mind. And this is another child where again there's a mid-shaft fracture. Also, this is not a standard fracture. This was sustained by a trivial fall, GMFCS4, cerebral palsy side. But you do notice that the moment you think about TENS, then you notice that there's a huge area here that's probably, rickets. And we are not sure how well the point of nail entry would fix the nail. So again, this was operated by my adult colleague actually who does trauma. So we discussed this, and then at that particular point we did not have LCDCP, so he just applied standard DCP. Not the ideal solution, especially you can see the width of the DCP is slightly more than what we would have liked, but this was done without disturbing the fracture site too much, allowed minimal disruption of soft tissues. And this is mainly we felt because it allowed early mobilization as well. So this is an obese child, the girl child who underwent TENS elsewhere, and you can see that it is about to fail. So they came to us in this situation, and you can see that it is about 4 months since the fracture was fixed, and you can see that there is some changes of atrophic non-union developing here, and there is a large bridging posterior callus which the body is trying to heal. But in spite of that, the nail is potentially failing now, and it may break. So one of the reasons why this may have happened is that you can see that this nail is not introduced proximally enough, and both the tips are pointing in the same directions, and the 3-point principle has probably not been adhered to. So we revised this and we introduced a locking compression. Unfortunately, I don't have the X-ray. I just misplaced it somewhere. So sorry about that. But we just did an open reduction. We took out the nail and we resected this posterior callus and we did a proper open plating. We achieved fairly good compressions and we introduced some local bone graft as well. The child is doing well. So this is another scenario that you might see. This is done by my colleague here. And you can see that there is a large fibrous dysplasia. And this child was actually under our follow-up when they sustained this. Again, a low energy fall. So how do you approach this situation? So the child is 14 years of age, 15 years of age. And you can see that the trochanteric epiphysis is all fused and the upper femur, lower femur seems to be okay. So you must remember that there is the adult tool in your armament. So you can use a locking standard rigid fixation device. And also it gives you a large working length and a good rigid fixation, especially in a situation where the entire femur has got various this fibrous dysplasia lesions. So it went on to heal uneventfully. So this is another child, 11-year-old, done by my colleague here. You can see that it is comminuted. There is a very large lateral cortical displacement here. And obviously it's very proximal as well. So the cases we saw earlier about the proximal femur, they did not have comminution. They had a stable cortical contact, which allowed us to get away with tens and a screw to fix, or a tens and a circulage wire, but that would be difficult here. So the other option we have is a submuscular plating. So the submuscular plating, you can do it in a so-called minimally invasive way. We can introduce it submuscularly. We can afford to stay off the bone and then just fix the two ends and have a large working length in between. These fractures generally do very well. So that's all. I think I've hopefully covered the various scenarios which we have as far as fracture shaft of femur is concerned, and then we can, I think, now discuss some more cases. Thank you.
Thank you for the presentation. So it's a lovely presentation, and the chart you provided initially according to age wise is excellent for every fellow. So there are some questions which was asked by the participants, like age and physis for intramedullary nail. What for extremely small child with undisplaced fracture? Do the tense nail do the care?
First is for the age. So you did mention in the chart an age limit for the consideration of intramedullary nail versus the tense nail. So locking intramedullary nail. So do you consider only age, or many a times we get children at 14 years of age who have the proximal as well as the distal physis which are open? And with that, the triradiate cartilage is also open. So do we have a look at the physis, or we just consider that this child has reached 14 years of age and now is amenable to unlocking intramedullary nail through the physis?
Yeah, actually, I think it was Dr. Venkat from Ganga who presented on his series of locked intramedullary nails, even in open physis, if I'm not mistaken. So age is not the only criteria, and if it is about to, there is very little growth left, you can take the X-ray of the hand, and if the distal phalanx still has the physis open, that is roughly a guide as to how many years you have growth left. If the phalanx has got the physis open, it means that about 2 years of, more than 2 years of growth is left as a rule of thumb. So then you can decide accordingly whether you want to interfere with the trochanteric epiphysis. We can potentially put a smaller nail so that the distal femur physis is taken out of the picture. And that all depends on the fracture configuration also. If the fracture is slightly distal, then you are in a little sticky wicket, and you may want to opt for a submuscular plating because you want a more distal working length. So age is definitely, only not a number that you have to consider other things, especially the amount of growth left if you are interfering with the trochanteric entry nail. So, so that's what. Yeah.
So in recent iFix, we discussed that the GT growth after 10 years is negligible. And now we see adolescents like young adult structures. So Dr. Sheetal mentioned that they have done trochanteric entry nail even in 10 or 11 years old. And that is obese kids, and that is quite doable. And now during this iFix also, we found that few companies have their prototype trochanteric entry nails. For the fractures with fibrous dysplasia or Olier's disease, where the shaft length is less, we have also used either tibial interlock or humerus interlock nails. And that's how it can work. But any trochanteric entry nail can be done, I think, after 10 years, if that fracture morphology asks for. So after 10 years, there won't be any problem with the growth, I feel. Everyone shows one case of growth arrest, which is my case, which I saw someone did Ender's nail from piriformis fossa, and it ended up in a significant coxa valga. But very few people have experience of AVN in the head after, they're using very big nail or significant coxa valga. So after 10 years, and the entry point should be tip of trochanter and not the piriformis. That should be the message. Yeah. Easwar, do you use intramedullary nail along with a temporary X-fix in some length unstable fractures?
For reduction, no. Reduction, we just go ahead and you're talking
yes, some of them are length unstable fracture, and you want to avoid this submuscular plating. We tend to put in monolateral temporary X-fix to
I have not used X-fix in femur, but that's definitely an option. Yes.
Yeah. Next question, Chinmay. Shalin.
Yes, sir. Yes, sir. Next question by Dr. Meet. Can we use a pelvic harness in age at 4 months? The case you shown us in the presentation, sir.
Yeah. See, that's what the pelvic harness is at about 4 months is a bit of stretch. We can use it, but I think 4 months means it's easily can apply a spica, and spica should be probably easily maintainable also. I would opt for a spica at about 4 months of age. Definitely.
And sir, one more question. How Ender's principle different from TENS nailing?
Yeah, fundamentally Ender is a stacked nail principle where you kind of, I actually was about to put, and I thought it might get very long. So I opted out of putting the Ender's nail. So you just introduce more and more nails inside. So it's stacking, which is working in Ender's nail. It is a cheaper alternative where you're probably working in a low resource setting and everything. TENS nail works on a principle of elastic recoil. So you have to obey those principles, otherwise it will fail. And it is only amenable to certain fracture types because it is using elastic recoil principle. So you need a less combination, you need 3-point fixation. So if you're not able to achieve that, and there is not enough cortical contact, then TENS nail is not the implant fit. Ender, since it's just stacking and you're introducing more and more nails and you're filling the canal, it probably works well for even slightly comminuted fractures.
So being in Gujarat and Ahmedabad especially, it's kind of Makkah of Ender's nail. And my professor, my teacher, Dr. Pankaj Divyetia, who brought this concept to India. But, early in my practice, we had a lot of CP children with shaft femur fracture with trivial trauma. The father tried to bathe the child and fracture the femur. And then I was wondering, they're usually a long spiral fracture. And then I took help of some adult colleagues, and we used to fix them with a stacked Ender's nails because their hygiene was not good to bear any open surgery or plating. And we used to give a unilateral hip spica. Unilateral hip spica after fixing with Ender's. I was always in fear that it would come out or child will not tolerate. But it's once the fracture gets fixed, the spasms go down, and you can give some muscle relaxant after. And they all did well. So all those fractures in cerebral palsy or very severe rickets, we opted to be away from plating because they all are inherently weak bones. And we had experience of the second fracture will happen at the end of the plate after some time. and then you have to revise the plating. So we kind of prefer intramedullary nail, and I've seen enders being used extensively in some part. That's
So one
also
more.
an option. Yeah.
Yeah, so after putting a tense nail in a child, do you immobilize him in slab or any hip spica, 1.5 spica, something like that?
Sorry, the question was not audible.
Sir, after putting a enders nail, after putting a tense nail
Yeah.
for bishop femur fracture, the older children, do you immobilize him in spica or just a slab?
I have not put spica in. In fact, I have not put spica in any child whom I have done tense nail on. At the most, they get a long leg slap and they stay in bed. Even I have used knee brace in children who are cooperative and the fracture pattern is stable. But it's slightly proximal fracture. Even I have gotten away with putting a little higher slab rather than a spica.
Sure,
Yes,
thank you.
Sometimes we
So
see
the-
cases. So what do you do for the entry point after inserting the tens? So do you use end caps? Because sometimes we have seen cases where the entry was, despite the entry being just above the physis, there is physial damage from the entry point and the child goes into either a valgus or a varus after a shaft femur tens nailing. So I think I saw 1 or 2 cases who were operated outside, which you showed at tens coming well below the physis. And we see in some of these cases, they have knee stiffness. And do you bend the tens nail at the entry point after the final fixation? Because I think I did not see any of the cases you did having a bend at the end. So what do you do at the end after the fracture fixation?
Yeah, especially when you bend the end, it does make it easier to take it out. But if you bend the tip, then it irritates the IT band and all that and gives all sorts of trouble. So I need to kind of leave it flush. My entry is well above. The X-ray might give you a false perception that the entry is probably low because you leave the nail long. But the entry is well away from the physis, and there is no reason you should get a physeal injury if your entry is well above the physis, at least an inch above, or 2 centimeters above at least. I bend the medial one a little bit because there is less irritation there. I feel the lateral one, if you bend and leaves it proud, it irritates the IT band and it causes pain, bursitis, and things. So after I enter, then usually what I do is either bend it with the instrument. I use the suction tip, the metal suction tip, and just bend it little proud on the medial side. So it makes it a little bit easy for me to take it out on the medial side. The lateral side, I just leave it a little long so that I can always do it, the bending, when I try to do the implant removal and then pull it out. So far, there is, at least in my series, there is no physical injuries.
Sir, how frequently you follow these patients? Radiographically?
I'm sorry?
How frequently you follow up this patient radiographically at 3 weeks, 4 weeks? What will be your protocol?
X-rays at 3 weeks typically after the post-operative period, and X-rays at 3 weeks and then at 6 weeks. That's all. Every 3 weeks X-ray till you knew.
Thank you, sir. So I think there is no more questions right now. We can go with the presentations, next presentations. Dr. Sheenam.
I think Dr. Meet would present the case first, and then if time is there, then Sheenam should present the case.
Meet, you can share your screen.
Yes, sir. Is it visible, sir?
Yes.
Okay. Good morning, everyone. So today I'll be presenting a case of shaft femur fracture in a 6.5-year-old boy. So this is a 6.5-year-old boy. He's a resident of USA and son of a senior orthotist who was practicing in Ahmedabad. He had a history of fall from bicycle and presented over there with a pain, swelling, and deformity of the left thigh. So this is the X-ray that we had. This is a lateral view. Unfortunately, we do not have the anteroposterior view for the same. So as we can see, this was a closed fracture at the distal third level of the shaft of femur.
Yeah. So now actually this patient is in US and the grandson of one of our senior orthotists here. So immediately they sent the X-ray to me that Molin by how we should get it treated. And 6.5 year relatively bit chubby, a complete fracture at this junction of distal. So what Ishwar, what would you suggest if your orthotist grandson has injury in US?
Do you have an AP of this? AP?
I mean, they sent it earlier, but in AP it is fairly kind of stable pattern, not much translated. What is more striking was in lateral view. So AP is more benign than this. So we usually have 4 options, right? Meet, can you go ahead with the next slide?
Yes, sir. Yes, sir.
Yeah, so Ishwar, just tell us your preference in this situation. 6.5 years old, moderately
That
built.
is a very chubby child that I would be doing submuscular plating on this. Difficult to
Yeah.
maintain in a spica if it is very chubby, and so
Still,
probably
this is doable through an antegrade TENS. Can't we?
yes, antegrade
Can
is another option. Yes.
or even retrograde? There is, I think, there is space to put nails from bottom. Can you go to the X-ray, Meet, please? I mean, we have some place. I have this juncture, and once you see the AP view, you will realize that yes, this can be nailed through retrograde. Yes, Charlene and Chinmay, what would you do this for this? 6.5 years. Yeah.
So 6.5 year with a chubby child, I will go with the antegrade nailing, sir.
Okay.
10
Charlene,
centimeters.
what? Yeah, I got it. So one C and one S curve, as Ishwar mentioned. Charlene, what would you do? Is he here or not?
Yes, sir, same integrate nails.
Antegrade nails. Okay. Right. So that I suggested either an antegrade or a retrograde TENS. I was pretty sure that I can do retrograde TENS. And then they forwarded this message to the orthopedic surgeon in America. And let's see what he did, what he chose.
So these are the 4 options that we have. This was a paper published in the IGO 2021, and it gave a age-wise and a fracture pattern and weight-wise protocol for managing a shaft or femur. So the patient is 6.5 years old. So they suggest if the depending on the nature of the fracture, if it's a fairly undisplaced fracture, then even early spica casting or skin traction with delayed spica casting can be considered. If the fracture is stable with a weight of less than 49 kgs, then they suggest TENS nailing. And with a weight of more than 49, as we have discussed in a chubby child, submuscular plating or flexible intramedullary fixation using stainless steel. So this was what was done in the USA, and this is the 1 week follow-up that we have for the same.
So that my orthotist colleague is now very much worried that, sir, we say that if you want to do the nailing, we give full freedom, and the surgeon said, no, I mean, I'm a bit scared of putting nails across an infection and this and that. We can treat this well with a spica. And there is some more angulation, in the lateral view after applying a spica. So Ishwar, this is 1 week follow-up now. In AP, you can see it is not much displaced, but in lateral, it is getting more angulated. So how would you approach it now?
Provided I'm continuing with the spica, I would wedge the spica at this point of time so that correct that angulation. It is a poor angulation, easily wedgeable and correctable.
Yeah. So Meet, show what is the exact angulation. And
so we have an angle of 31.1 degrees at the site.
So at the age of 6.5, what is acceptable? Yeah, Meet.
So how would everyone like to approach it now? Would you like to continue with the same spica, reapply the spica with some correction, remove the spica and pass an intramedullary nail, or would you like to do something else? So coming on to the acceptability criteria for the diphageal
So-
femur fracture.
So before going to that, Dr. Easwar say that he would like to wedge this spica. Chinmay, what would you do?
Yes, sir. I will also think about wedging.
Wedging. Shalin,
Yes, sir.
sorry, wedging.
Yes, wedging, sir, because
Okay.
15 degrees, I think the acceptable angulation at more than 6 years of age is almost double. So needs to be corrected. So if we are taking him under anesthesia, wedging again wouldn't happen without it. So if it is well early on, within a week, we can consider tense nailing
Mhm.
to stabilize the fracture which is once displaced already.
The question is also if we do wedging and if it gets further displaced at 2 weeks, then probably the fracture would start gluing and we won't have much time there to put a nail. But wedging is definitely an option. Yeah. Fine. So Meet, go ahead and show what was performed.
So this is from Rockwood and Wilkins 8th edition, and as we can see here, from the age of 6 to 10 years, the anteroposterior angulation, the acceptable limit is for just 15 degrees.
Yeah.
So now this was the 1 week follow-up that I had shown previously, and it has an angulation of 31.1 degrees. So would we accept the angulation or should we do something else? So the surgeon opted for wedging of the cast, and this is what we have now at 1 week after at the just post the wedging of the cast.
What
As
is
we
angle?
can,
Yeah.
as we can see, the angulation has reduced from 31.1 degrees to 27.5 degrees.
So what I was informed that this in under wedging they found substantial correction, but in follow-up again there is some sagging and there's 1 week post wedging 27.5 degrees. So Ishwar, at 2 weeks after injury, 1 week after wedging, this is the lateral view. Should we accept it or should we do something else?
I mean, this is not acceptable at this age. We have to correct it. So there are two options. Either you can take under child under anesthesia, osteoclasis, and a new spica, because I can see that there is quite a lot of gap between the skin and the spica itself. So I assuming that the spica has become loose at this point. So a new spica is definitely an option. If it is too sticky and then it doesn't come at 2 weeks, then we can consider antegrade nailing. I would think about antegrade nailing with an osteoclasis.
So at this juncture, they made me talk to that orthopedic surgeon, and it happens so that it is easy to opine when you are on the other side of the table. I was of the same opinion that this is not going good, and if it goes further, then the child might need some secondary surgery. And he said that one good thing he said is that we should consider the bowing of opposite femur also. So we don't aim at 0 degrees. There is always 15 degree of bowing in the normal femur. And looking at the age of child, I feel that this will remodel. So I don't want to do anything further, and we'll just wait. And the skin contour under the spica doesn't look very bad. So I said that that's right. And so he opted to continue with this spica. And once the radiologic callus is seen, they switch to a walking spica, unilateral walking spica. So that, and I agreed with him looking at this plan. I said, yes, if needed, then we'll do something else in future, but do not, let us not open or put nails at this point. So we had a long discussion, and that's what he was inclined to do rather than putting nails. So let's see what happens next. Yeah, Meet, go ahead.
So this is just a paper about the wedging of the cast, which suggests that the average angle that the average correction that has been obtained ranges from 7 degrees valgus to 2 degrees varus, and from 7 degrees of recurvatum to up to 2 degrees of procurvatum. This was published in the JPO 2018. So now at 3 weeks, the bilateral hip spica was considered to a walking hip spica. So as we can see, the patient ambulates with the spica, and this was a paper published in JBJS 2011 by John Flynn. It suggested that the orthopedic outcomes of the walking hip spica resulted in a lower care burden for the family. And however, there was always the risk of a great that the wedging adjustment of the cast might be necessary due to fracture malalignment. So this was a 3 weeks follow-up with the walking spica. At 6 weeks, the walking spica was removed. And as we can see, there's a good amount of callus that has formed now. And this is the follow-up we have at 6 months. This was the 1 year follow-up. We can see the thickened callus has now shifted to the diaphyseal area. The anteroposterior alignment seems perfect. And the child is a taekwondo master. He has a black belt in it. And as we can see in the first image, he can bear complete weight on the left limb, and he has no problems, no functional problems at all.
Yeah. So it remodeled well, although the grandfather said there is a small bump when I feel his thighs in the front, but he's strong and he can do all the activities. He's also a swimmer. So this is, I know that the family and the doctor would have gone through a lot of turbulence and, you know, challenges and stress points in the treatment, and the outcome is good. But doing a nail at the outset, that might also be an option, and the surgeon and the family would be at ease if the nailing has been done in a right way. But this case suggests that there are extended indication of each treatment, and if a senior guy says that I would treat with plaster, so that is also doable, and the children can have a good sporting life after that. Easwar, your comments on this?
Yeah, it illustrates that, you know, you don't need to always stick to the operative things, but operative things in a modern lifestyle and a demanding parents is also puts everybody at ease if you have a reduction up front, and then you don't have to wait for the remodeling to show to the parents that it does remodel. So
yeah, so I was surprised that the BZ Center in New York, where they are like, you know, they are behind putting nails, and this surgeon was like treating conservatively. So I think, yeah, there are surgeons following the principles, what they have learned, you know, in their training, right? So I think we have 5 minutes, and thanks Meet for nice presentation and review of literature. I would invite Sheenam to take us through Orthokids practice of this, you know, hip spike application and the mobilize, how we try to smoothen the post spica care in children so that it is very readily acceptable to the families. So Sheenam, are you there? Would you share your screen?
Yes, sir.
And Sheenam will take us through our design of spica table. He shall take us through our Spica technique and the hip spica stroller, which we have designed, and we use it for all the patients of shaft femur or DDH. Yeah, Sheenam, please go ahead.
Hip spica table, hip spica cast, and is oftenly used in traumatic as well as atraumatic conditions. A straight spine and pressure-free abdomen are essential for the child's comfort. With this, the evolution of the hip spica application device started from a simple stand to a box table to a modern leg holder. The main goal of designing this hip spica table was to provide a portable device and inexpensive device. This hip spica table has two parts. We can see here acrylic sheet and metallic base. This metallic base has 3 bars over it and with 3 knobs to accommodate the acrylic sheet. Acrylic sheet has holes to accommodate the knobs over the metallic bars. We can see here the child with head is supported with pillows, and this spica table can bear weight up to 50 kgs. This is a top view. We can see child is comfortably placed over the hip spica table. These are the dimensions. We don't need to go into the detail of dimensions.
So this spica table has a place underneath, and so it is easy to apply the spica. And secondly, when we remove this acrylic sheet, there is enough space around the tummy so that you don't need to put the window around umbilicus or so. So that will be seen in this spica application video. Is it playing, Sheenam?
Yes, sir. Firstly, this is the table shown here. Firstly, the child is.
Sheenam.
Not being shared. You need to share the YouTube screen itself. Right now, you have just shared the PPT screen. So
Okay.
I think you need to share it.
So Sheenam, what you need to do is you have to close this presentation, and then you have to go to YouTube and play from there, I think.
Yeah, you have to stop share and then share again, selecting the YouTube screen.
Okay.
Or what you can do is, in meanwhile, you can finish this stroller part, and then you finally show this, so that people, you can show the stroller design if you wish. Yeah, hip spica stroller. So make it a full screen, please. So Sheenam, we are not able to listen to this, so you can take us through.
We devised this device for the safe mobility for the child after hip spica application. This stroller is simple, affordable, and low profile. The basic frame is made up of 25 into 25. Seating arrangement connects the main frame at 90-degree angle and seat has 25-degree inclination. We can adjust the sitting bars according to the size of the child. These are the actual images of hip spica stroller from the side and back view. There are 5-point safety harness and adjustable holding bars as shown in the video. This is an X-ray 3 years old girl with right side VDH, and we can see the child is mobilizing on the second day.
Yeah, so Easwar, we have been using this stroller on a hospital-based loaner program. So we have around 5-6 such stroller, and all the hip spica patients take it with them, and they pay some deposit, and once they return it back, we give them money back. But this makes the care very easy. We teach families to how to put this child on the stroller in the hospital. On day 2, they are mobilized. On day 3, patient has been placed and secured by the family itself so that they can do it confidently once they go home. And we have found very good feedback. Um, some families, they ask that, sir, can we retain this stroller even after spica is removed, because they are so comfortable. And the extended use is they put the child on this and then they finish their potty and the hygiene part. That is very easier than to do when they are up reclined. But the main advantage has been the care burden on family has been less, because they don't need to hold the child, and child spends a lot of time upright rather than being reclined and having issues of back, the ulcerations and perspiration and all, or respiratory infections. So this is a good help, and I suggest all of you to keep 1 or 2 such strollers in your hospital and loan it to the families. This paper was also published in IJO.
Yes.
So we can share these details and designs also if you want to make it. And now our orthotist can courier it to you as well. So the person who is making this stroller. Yeah, Sheenam, we have 5 minutes past. So let's quickly go through the hip spica application technique.
Okay, sir.
Or I think hip spica, let us stop here. And final comment, Easwar?
Yeah, I think overall, I think it's a very nice session on where we share our experience about femur fractures, a little bit of theory and what we do here and what you do in Ahmedabad. So it's very nice, and especially since you mentioned about how you use Ender's nail, something we've kind of forgotten in cerebral palsy. So I am not even sure whether Ender's nail is available in Kerala anymore. So
yeah, so there are a lot of I can share some, and as you might know that there was a paper from I think Texas Scottish, right, and they have compared Enders with TENS, and they have found them more stable, and they do not undergo bending when you use stacked nails. And they have used it for old children between 40 and 60 kg body weight. So that's now coming up that stainless steel implants are coming up again. I think thanks, Easwar, for your time. It was a wonderful session, and a lot of pathological fractures you have shown. So shaft femur fracture is not only this trauma, but it was also pathologic fracture. So I think, yeah, there is one last question by Puneet, and Easwar can answer, and then we'll wind up the session. Shalin, we cannot hear you. Can you be loud?
Yeah. So how do you assess rotations while applying spica in a femur fracture?
How do you assess rotation? Now, for femur fracture, assuming it's for femur fracture, you have that 30-30 position I talked about, and you have your eye on the patella all the time and the ASIS. So I do it in segments. I do the body segment first and then connect the body segment to the thigh segment. And as we cover each segment, we make sure that the segments align up. So once you have covered the ASIS, then you don't have the guide of ASIS. So until that is done, you make sure the ASIS is aligned to the patella, center of patella. And once you finish the thigh segment, you ensure that the patella aligns to the second toe. Yeah. So you wait till it sets and then move on to the next. Otherwise, it becomes very clumsy. The person holding the reduction and the person actually putting the spica, the toggle happens if you try to cover the whole stretch in one go. So I do it in segments and then link up the segments.
The other way to look at the cortical width in an X-ray or IITV, that also can guide you that there is not much rotational malalignment. Right, Easwar, thanks very much for that lovely presentation. We'll catch you later again. Thank you very much, all the fellows. Thanks for the hard work. Have a good day.
Thank you.
Thank you.
Bye. Bye, Easwar. Yeah, take care.